Thank you very much, and thank you for the invitation to give this talk. As you heard, I work in the UK, and I'm the director of a Haemophilia Center, which is a comprehensive care center. So I'll give you my perspective of comprehensive care. This is what is the World Federation of Haemophilia definition, if you like, of comprehensive care. It's rather long, but basically it says that the wide-ranging needs of people with haemophilia and their families are best met by coordinated delivery of comprehensive care by a multidisciplinary team of healthcare professionals. So this is what I'm going to be talking about, the fact that care for haemophilia is best delivered by multidisciplinary team of health professionals. We, as part of a project a while ago, looked to see how many haemophilia centers there are in Europe. And we found 409 centers that call themselves haemophilia centers. I just wanted to point out to you a center, because I'm going to come back to it, and my next map doesn't have it, which is there, and I believe that is Samara, and I'll come back to that. So what is a haemophilia center? Well, there is no acceptable definition. Anybody can call themselves a haemophilia center. There is great variability. In the severe haemophilia patients, there are some centers that are more than 350 severe patients registered to them, whilst there are others that have less than 5. The laboratory services offered is enormously variable, as is the on-call care service provision. There are some countries that have more than 80 haemophilia centers, whilst there are others in Europe that have only 1. And they can call themselves anything. So the key issues really for a haemophilia care center are the range of staff and services that they offer. I'll come back to the issue of minimal patients, the 24-hour care, and the laboratory backup. This is the key slide from my presentation. Comprehensive care involves providing a range of services. I've outlined their nurses in red because it's my strong belief that the future of haemophilia care is going to be delivered primarily by nurses with backup from the other workers of the team. And that is increasingly what's happening in the UK. You have doctors, but also integral to the multidisciplinary team are physiotherapists, orthopedic surgeons, and social workers who are sometimes psychologists, sometimes not. It varies between countries. But these are the key components of a multidisciplinary team that provides comprehensive care center. But it's no good having just these specialties. You require access to other specialties as well. And I've put the other specialties there: psychologist, pain specialist, liver specialist because of the hepatitis C issue, HIV specialist, obstetricians to manage our future patients, gynecologists to manage the heavy periods in women, dentists, and genetic services. There are a number of issues regarding the range of services. The optimal is to provide all the services from one hospital. However, that is not always possible, and we recognize that. It's also ideal to have one person leading a service. For example, in orthopedic surgery, it's good to have a single person that leads that service, even though that person may not do all the surgery or see all the patients. And we'll hear from an expert on this area later on. Some services may be provided from another hospital, but the issue is that you have to have good arrangements from the other hospital to provide those services. And it's not about wealth and product availability to provide comprehensive care. You can do it in countries that are not the most wealthy in Europe. And actually, one of the countries in Europe that is probably in the top 3 in terms of wealth has a major problem in providing comprehensive care in their capital city at the moment. And you require the patient group and the health professional group to work together to provide advocacy to expand the service provision. So a comprehensive care center should have something more than just the staff. It should provide 24-hour care. It should have protocols. As a minimum, it should provide clotting factor concentrates of 8, 9, and von Willebrand factor. But depending on the health mix of your population, you require other concentrates as well. You should provide regular reviews of the patients in clinics. You should provide patients with individual management plans. I believe a key is also to have a registry of the patients attending your center. You should provide data collection, and you should perform audit. And I'll deal with that last point in my penultimate slide. Some of you may know this paper that was published in Haemophilia recently. It was published by Brian O'Mahony and the European Haemophilia Consortium. I'm sure several speakers during the next 2 days will refer to this paper, and I notice on the wall of one of the stands there is a big poster with all the availability of centers and the services in Europe. So this is what Brian did, and the EHC was to ask a number of countries, all the countries actually in Europe, as to what services do their centers provide. And you can see the countries on the left that are included because they answered their questionnaires, and you can see the countries on the right that are excluded because they did not answer the questionnaires. This is a figure from the table, and what it shows is that as the income, as the GDP, the gross domestic product, in terms of wealth of a nation increases, the amount of factor VIII usage per capita of the population is increasing. So the red bars is how much factor this country uses, and this is its wealth. And as you can see, in Europe, there is an amazing disparity, both in wealth and in clotting factor usage. And some of the countries in Europe are the highest users of clotting factor in the world. So this is from this paper, lots of words, but let me take you through it because the points are very simple. This is what the paper asked. Do you provide these services that are normally provided by a comprehensive care center? Only 7 centers, i.e. a fifth, said they provide all of these services in their centers. And you can see the countries there that said they provide these centers. At least this is what the patient organizations have said, and we cannot be sure that all centers in that country provide all of these services. Most of the centers in Europe do really provide orthopedics, emergency care, acute and general surgery. But the point to make is that there are very few countries that are actually providing true comprehensive care because they're not providing really social work support, psychology support, pain management support, or rheumatology support. I'm going to show you a slide that probably many of you in the room do not appreciate the importance of, because the haemophilia population is changing. This is one of our patients who will be age 93 next month, and he has severe haemophilia. And what you see here, he's the secretary of his local shooting club. and he couldn't be very accurate when he was shooting. So last year, he persuaded us to do surgery for both his cataracts in his eyes, which we did. And he wasn't any better afterwards, because the reason he wasn't very good anymore is because his joints were not so good in his arms. Furthermore, last year, we replaced his knee for a second time. He had a knee replacement at the age of 72. So he thought, if you've got severe hemophilia and you have a knee replacement at the age of 72, you'll do quite well, you'll outlive your knee. But actually, he had a knee redo surgery at the age of 92, and he did very well. He's also got all his other joints replaced. But the point I'm trying to make here is that these patients are around and are increasing. The number of people over 80 are increasing. So we're now having to use cardiology services for people with hemophilia who are having heart attacks. We need anticoagulation services. We've had 3 patients with hemophilia requiring anticoagulation over the last 6 months. It's not something we ever thought about before. So it's a bit of a crazy thing, isn't it? You have a patient with hemophilia, and you're giving them anticoagulants. But the future is going to be more of a problem in this area. We need ophthalmology when people are getting cataracts. We need geriatric care as the people get older. And this is a real problem. What happens with a patient with hemophilia when they're starting to get demented or when they start falling? That is a real problem when a patient with hemophilia starts having falls that they cannot control. We'll address this later because we're going to suggest that you need a certain number of patients to have comprehensive care center. But what should that number be? You need to have some experience and to maintain that experience. Should you count only severe patients? Should you count only severe hemophilia? What about, there are certain parts in Europe where the population is immigrant and they marry their cousins, so they have rare bleeding disorders which are severe. What about sparsely populated areas? What happens if you live at the top of Finland and such a big area with very few patients? If you're a comprehensive care center, you have to provide 24-hour care. For severe hemophilia, until now it's been assumed that the 24-hour care is really to deal with severe hemophilia. But in my center, the 24-hour care is not actually for the severe patients, that is primarily, because our patients are on prophylaxis and they don't cause us really any problems, the severe patients. It's the mild patients that are really the issue, that they turn up to a hospital and they need surgery and people do not know how to manage them. Or the new patients with acquired hemophilia that develops in older age. And it doesn't really matter what you have, because if you're a comprehensive care center, you have to deal with this. You may not do them yourself. Ideally, you should if you're a comprehensive care center. But if you're not, you have to have very close relationship with a center where the patients will have to go. So if your patient needs anything 24 hours a day, they need to know where do they go to get that care. What about the coagulation laboratory service? What's happening in Europe is that this is not considered to be key. People like me think that's untrue, because hemophilia does not lend itself to large volume batch tests. That's what laboratories want. They don't want to do a factor VIII in the middle of the night on its own. They want to put all their factor VIII levels, send them to a laboratory, and get the results, once a month. That's really cheap. That's what they're interested in, getting them done cheaply. But for the hemophilia population, you want an accurate result 24 hours a day. So it's no good getting accurate result a month later if you need it urgently. You need an accurate result, you need a range of tests. If you're not going to do it yourself, you need to have an arrangement with another center. And when I tell you accurate, you probably all think that when one of your blood samples is sent to a laboratory, you get an answer and it's accurate. Well, let me show you some data from hemophilia centers. This is a sample after a patient with severe hemophilia was given factor VIII. And what you see here, this is the same sample sent to all of these laboratories. And the range of results range from 25% to 85%. This is the reality now of laboratories that are calling themselves experts. So this is not in small centers when they don't do a lot of tests. Okay, I think this is my penultimate slide about audit. These people are scared about audit because they think they're being examined by someone outside and they're going to tell them what to do. Actually, audit is very key, and we all encompass it now. In the UK, we do it every 3 years. We have a doctor, a nurse, and a patient from another center, from another part of the UK, there are different centers, come to us and examine our services over 1 or 2 days. There are standards they compare us to, and they publish the report. And it identifies parts of the service that are not offered. And it's a really very good stimulus for providing the service. We actually tell the auditors what is bad about our service because we want them to put things bad about us in the report. We've told them we didn't have a social worker and we wanted one. And the auditors put that. And when that goes to all the authorities, they see we have the deficiency. And now we managed to get a social worker as part of the audit. And this is my last slide to direct you to 3 documents about comprehensive care, or they contain about comprehensive care. There is a document about the principles of care published by the European Association of Haemophilia and Allied Disorders. There is a document of standards of haemophilia care that will be presented later. And there is a World Federation of Haemophilia document online. Thank you.